Welcome to the pre-module presentation for the Ontario Health Team Learning Series, which is launching on Zoom on Monday, December 5th from 11:30 to 1 p.m. So my name is Carrie Koleski. I'm a research chair in patient and family-centered care at the Institute for Better Health at Trillium Health Partners. I had the honor of co-designing this learning series with a number of patient and caregiver partners across Ontario, along with Ontario Health Team leads, clinicians, researchers, people in decision-making roles, trainees, and members of the community over this past year. I'm recording this presentation from Toronto, so I will read the land acknowledgement, followed by the African ancestral acknowledgement for the City of Toronto. We acknowledge the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. The City of Toronto acknowledges all treaty peoples, including those who came here as settlers, as migrants, either in this generation or in generations past, and those of us who came here involuntarily, particularly those brought to these lands as a result of the transatlantic slave trade and slavery. We pay tribute to those ancestors of African origin and descent. The purpose of this pre-module is to review some history and key concepts in preparation for the learning series. Here is an outline of what I'll talk about. First, I'll review what we mean by patient and caregiver engagement, including why it matters. Then I'll do a quick history of engagement in the healthcare system. I'll review a few key engagement frameworks and concepts. I'll talk about engagement tensions. I'll talk about what makes engagement meaningful. And then I'll get into how the OHT learning series was developed by providing an overview of the sessions and conclude with a few remarks around the benefits of taking the full engagement series. And the power of creating this engagement series in partnership with so many different people is we actually emulated the core principles of engagement and co-design by the way we worked together, negotiated together, set priorities together, and worked through uncertainties together, which is really the essence of what we're teaching in this learning series. And it was a really, really powerful and impactful way to build the series. And also, we're really excited to share what we've learned through the learning series itself, which will be delivered in 90-minute sessions over Zoom each month. And I'll provide some details later on in the presentation. So what is patient and caregiver engagement, and why does it matter? Kristen Carman, the Director of Public and Patient Engagement at the Patient-Centered Outcomes Research Institute, otherwise known as PCORI, defined patient and caregiver engagement as the following. She said in her paper, patients, families, their representatives, and health professionals working in active partnership at various levels across the healthcare system, direct care, organizational design and governance, and policymaking to improve health and healthcare. In her paper, she also references James Conway, who's from the Institute for Healthcare Improvement, and he talks about engagement in terms of how it is organized, so in a similar fashion. So he notes that it's organized around the settings in which the engagement occurs, during the care experience, within the clinic or ward, within the broader healthcare organization, or within the larger community. Most importantly, engagement is required if we want to have collective impact. So what is collective impact? The National Council of Nonprofits defines collective impact as an intentional way of working together and sharing information for the purpose of solving a complex problem. Similarly, a paper in the Stanford Social Innovation Review, written by Hanley Brown and colleagues, noted that the complex nature of most social problems belies the idea that any single program or organization, however well managed and funded, can single-handedly create lasting large-scale change. So what they are saying is that collaboration or engaging with different partners is absolutely essential when trying to make a difference or when trying to achieve collective impact. I really like this quote by Catherine Milligan and colleagues, and Catherine is the director of a think tank called the Collective Change Lab, which provides guidance for attaining transformational change. She talks about the importance of relationships in her paper called The Relational Work of Systems Change. And she says that relationships are the essence and fabric of collective impact. What's critical for those who facilitate collective impact efforts is to support relationship development in ways that build true empathy and compassion, which is the focus of session 1 of the learning series, so that authentic connections happen, particularly between diverse participants. These deeper connections can form new avenues for innovation to address the social problem at hand. Further to that, she says, sometimes we lose sight of a simple truth about systems. They are made up of people. Despite all of the frameworks and tools at our disposal and all of our learning as a field of practice, purely technical, rational approaches to systems change will not make much of a dent in shifting power or altering our most deeply held beliefs. If most collective impact efforts fall short of supporting people to change in fundamentally consciousness-altering ways, then the system they are part of will not significantly change either. So this quote really speaks to the importance of investing in time to build relationships with each other, to build trust, and through that, learning from each other and learning how to work differently in order to support system change. So in addition to aiming to have collective impact, why do we engage? Why do we do this work? First of all, engaging with people who have lived experience related to the problem we are trying to solve can make the strategy we are working on more applicable to them. There may be greater uptake of new programs and services that are developed. It can potentially improve outcomes and experiences of patients and families, as well as it pushes us to focus on outcomes and goals that matter to people, including to patients, community members, caregivers, and family. When we engage, how do we do it? Or in other words, how should we do it? First of all, we need to engage meaningfully, so it's valuable to our partners, including patients, clients, community members, families, care providers, decision makers, basically all the people we are working with. We need to engage actively with the intention of creating needed change. We need to avoid tokenism, and later on in the presentation, I provide insights on how to do that. And we need to engage in partnership, so share ideas and try to establish and work towards common goals. Now we'll get a little bit into the history of engagement. I'm going to touch upon engagement in different spheres, hitting on patient advocacy, community-based participatory approaches supported through policy investments, as well as research-initiated funding, and even some local examples from Ontario. So we can think about engagement as occurring in multiple realms, including in research, in the health system, in public policy, and the broader community. I'll focus this little history segment on engagement in the realm of the health system and health research. In the 1960s and 1970s, there was a growth in patient movements, including women's health movements and childbirth, reproductive rights movements, and a push for more inclusion of women in medical research. And during the 70s, women's health needs were a lower priority in the scientific and medical fields, and even caution was expressed regarding allowing women to participate in drug trials. Excluding women from early stages of drug trials led to a shortage of data on how drugs affect women. So many people believe that individual women should be allowed to choose whether or not to take the risk of participating in research. A 1985 US-based report recommended research on how behavior, biology, and social factors affect women's health. So you can see that when we exclude people from engagement and in research, we don't have the knowledge that is required to improve things for that population. In the 1980s, there was a growing support for participatory research focused on conducting evaluations with local partners and collaboration with state and local health departments and citizen groups. In the 1990s, we continued to see disease activism. So, for example, in breast cancer activism helped increase federal funding for research by framing breast cancer as a social problem. And then the AIDS crisis occurred and community-based responses stepped in. Our community members stepped in to address education, advocacy, and research because government and the medical community was lagging behind. As we move into the 2000s, there was increased policy and funding support for patient, caregiver, and stakeholder engagement, as well as researcher-initiated engagement spurred by funding agencies, including the Canadian Institutes of Health Research in Canada, the National Institutes of Health Research in the UK, among others. To share an Ontario-specific example, we can look to the Excellent Care for All Act, which was put into law in June of 2010 in Ontario, with the goal of strengthening accountability to deliver high-quality patient care. The legislation sets out a number of requirements for healthcare providers, and it's laid out in the Public Hospitals Act. And the legislation requires that hospitals establish quality committees to report on quality-related issues, to put annual quality improvement plans together and make it available to the public, to put patient and care provider satisfaction surveys in place, to develop a declaration of values following public consultation, and establishing patient relation processes to address and improve the patient experience. Another example comes from Accreditation Canada. In 2015, they developed standards for client and family-centered care that include involving patients in advisory groups, collaborative teams or initiatives to design or improve care processes. So those are some examples across patient advocacy, community-based research, government initiatives, and research-initiated initiatives. So now that we've walked through a little bit of history on patient engagement, let's talk a bit about some of the frameworks and concepts related to engagement. In looking at patient engagement frameworks, this old classic one from 1969 was developed by Sherry Arnstein. It was designed to describe citizen involvement in policy and planning, and it presents a hierarchy from low to high engagement. In fact, if you look at the bottom, there's really no engagement. Through when people might experience manipulation or they're told what to do, maybe through therapy and other means, all the way to the top where citizens have full control. But the framework itself has been heavily critiqued over the years, including by authors Tritter and McCallum. So for example, they say that this particular hierarchy or ladder assumes that citizen control is the ultimate goal, when in fact, different levels at different times for different people make sense and is more reflective of authentic engagement. It does not capture co-production and partnerships between different types of stakeholders. It doesn't capture the quality that different forms of participation bring. It just assumes that citizen control is the ultimate goal. The latter does not take into account the depth of participation, including whose voice is at the table. So really, when we think about engagement and co-design in the health system, we want to see partnerships between different types of stakeholders. So between members of the community, patients, families, care providers, decision makers, etc., in working together in shared purpose to understand the issues together, to bring their different sources of knowledge to bear, and to work together to improve things. And so this particular ladder doesn't quite capture the different levels of engagement amongst different stakeholders. So moving to another framework that kind of captures more of the collaboration between stakeholders is this one. And this framework was created by Dr. Antoine Boivin from the University of Montreal. And it expands on a well-known framework that was developed by Kristen Carman, and that the Carman framework also gets at different types of engagement and different degrees of engagement. So I quite like this framework because it captures the different spaces where engagement can take place. So direct care, research, health services design, delivery, and policy. It also captures different degrees of engagement, ranging from information towards patients, such as sharing information on research results or diagnoses, to consultation, such as doing surveys or focus groups, to partnership, which is really where our focus is, which includes involving patient and caregiver partners on quality committees, co-design activities, research teams, and decision-making tables, etc. The next framework, which was developed by Dr. Jean-Louis Denis and Ross Baker, which I've added a few modifications to, outlines what needs to be in place to make organizations engagement capable. So here you will see there is a role for leadership, a role for providers and staff, and a role for patient and caregiver partners. And all of these roles need to be activated. So for example, some key questions that organizations and people within them can ask themselves is patient and caregiver engagement a core value of the organization? Is it part of the strategic plan? Are organizational leaders connected to patient and caregiver partners in a meaningful way? How do they communicate together? Do staff understand the importance of patient and caregiver engagement? Are patient and caregiver engagement practices embedded in their day-to-day work, or is it on the side of their desks? Are care provider barriers to engagement understood and addressed? Do patients and caregivers have the tools needed to engage? Do they feel comfortable? Are their needs and backgrounds understood and acknowledged? Are there barriers understood and addressed? So Ross Baker and colleagues who are now at Healthcare Excellence Canada, including Carol Fancott, and they worked in collaboration with Maria Judd and Christine Micah to develop a case book. And in the case book, they looked at organizations that were doing patient engagement practices particularly well. And based on the findings of those cases, they landed on this framework and started to really understand how all of these pieces work together. They found that the most successful organizations started small, such as on one unit or program, and then grew from there. The framework also speaks to the importance of doing what I will refer to as deep relational work. So quoting from the paper I referred to earlier on the relational work of systems change, the authors note that, and I quote again, by deep relational work, we mean a fundamentally different way of being in a relationship. It starts with creating a space for the work that is viewed by all, especially those who do not have institutional power, as a safe environment where participants can express themselves freely and be vulnerable, connect with each other, and experience their common humanity. It is particularly important for leaders of collective change efforts to walk the talk in modeling vulnerability, and to create the conditions that encourage those in power, such as funders and board members, to do the same. So in thinking about the quote in relation to this framework, there's a fundamentally important role for leaders to set the tone and create the context for patient and caregiver engagement to successfully occur. In a book chapter by Glenn Robert from the UK called Participatory Action Research, Using Experience-Based Co-Design to Improve the Quality of Healthcare Services, he reviews a number of relevant concepts that are sometimes used interchangeably with engagement and co-design. One is user-centered design, and while this term might seem new-ish in the world of healthcare and patient engagement, user-centered design is rooted in the design sciences, particularly architecture and engineering, which includes activities like co-design and prototyping. So imagine designing a consumer product like a cell phone or some other type of tool without considering the preferences, behaviors, and the needs of consumers. And so user-centered design really puts the user at the center to understand how best to design products. Co-production is also used interchangeably with co-design, and co-production can be defined as working with citizens to design and deliver new programs and services. And trust between different parties, so professionals and service users, is needed, and all parties need to take risks, and that comes from a paper by Bavard. Finally, learning theory is relevant here, and it's all about reflecting, creating safe spaces to have ongoing conversations, and changing course when needed. So all of these concepts are somewhat related to and overlap with engagement and co-design. So let's take a deeper look at co-design. So if we want to simply define co-design, it really refers to working together to improve something, and it could be both a process and an activity. Importantly, it requires sharing power. And I really like this quote by Liz Weaver, who's the co-CEO of the Tamarack Institute. And she said, "It starts with collaboration. This is the coming together of two or more organizations to work collectively, share authority, decision-making, and accountability to influence or resolve community opportunities or challenges. Collaboration is viewed as an opportunity for partners to create something new or scale up an existing approach together that might be impossible for a single organization to do on its own." So this is particularly relevant for Ontario health teams, which comprise many different stakeholders, many different organizations coming together to do a better job together to tackle some of the healthcare system's challenges. There are many steps and methods for co-design depending on what source you're looking at. But you can think of it as being comprised of three core stages. So you have a pre-phase, you have an activity phase, and then you have an evaluating looping back phase. So the pre-phase is sometimes forgotten about, and this is where you're building relationships and essentially finding your people. So when you're preparing for the co-design activity in the pre-phase, you need to think about, are you including those that are affected by the problem that you're looking to address, as well as those in a position to do something about the problem? And it takes a while sometimes to build those relationships. And I like the saying, you have to go slow to go fast. And so spending some extra time in this pre-phase is critical and will pay dividends in doing more authentic engagement and co-design in the next phases. The activity phase is the actual activities that you do to co-design a new program, a new service. You might work in small working groups and answer key questions, build something together, or try to improve an existing service. So you might be redesigning something or starting from scratch and designing something new. The third phase, the evaluating looping back phase, is also often forgotten about. And it's about asking your participants, how did it go? What worked well? What can we improve on? But also keeping people in the loop. It might take a while to go from the co-design to the implementation phase. So it's really important to loop back with participants to say, thank you for your time. This is the information that we used from you. This is what we didn't use and why. And this is where we're at in terms of implementation. This is why it has stalled. This is why it's taking long. This is when you can expect to hear back from me next. So it's really important in order for people to feel valued and to continue to feel part of the community is to take those steps to keep people in the loop and also continue to do some evaluations so you can improve the next time you do the co-design work. So now that we reviewed some of the fundamentals of co-design and the key steps, let's get into some of the tensions that might be experienced when doing engagement and co-design work. First of all, we don't always see the same thing. And I'm using this slide inspired by a presentation given by Dr. Francine Buchanan. Is it a 6 or is it a 9? Depends on our vantage point. We might not value things in the same way. So here's a funny little clip. Cats are walking on the beach and they say, why would anyone want to vacation in a giant litter box? So regarding the same thing, we might have very different ideas on how valuable or what something could be used for. We might be skeptical of other members of our team. And here's me trying to be funny again in this little picture on teamwork, where it says, ensuring that your hard work can always be ruined by someone else's incompetence. And let's be serious, these thoughts cross our mind. We can get really frustrated sometimes with members of our team. We might not create space for everyone's viewpoints. So Adam Grant, who's an organizational psychologist and researcher and professor at the Wharton School of Business, said, when groups defer to the most assertive person in the room, they reward confidence over competence. The danger of speaking with conviction is that it can stifle critical thinking and silence dissent. We learn more from people who explore ideas than those who attack and defend. So anytime we get a group of individuals together, there's going to be some voices that emerge with more confidence, that come out more loudly. We have to think about how do we get the perspectives of the quieter people in the room, but also create a space where people that might think differently feel safe to speak up and share their ideas as well. We might not appreciate the knowledge of others. And here's a tweet from Trish Greenhall, who's a UK researcher. And the use of this slide is inspired by a presentation given by Frank Gavin, who's a patient leader in our community. And the doctor said, don't confuse your Google search with my 6 years at medical school. And the patient said, don't confuse the 1 hour lecture you had on my condition with my 20 years of living with it. So really, both sources of knowledge from the clinician, from the patient, are absolutely critical. We have to create the space for us to appreciate that we bring different sources of knowledge to the table, and it's valuable, and it's needed in order to solve the problems that we face. And we might not, to that point, we might not consider patient and caregiver experience to be valid sources of evidence. And Betty Lou Christie, who is the director for Support House's Center for Innovation and Peer Support, and also the chair of the Minister's Patient and Family Advisory Council in Ontario, shared a really powerful quote, really showing that personal journeys equals living expertise, which equals experiential evidence. And she said, when allowed full and equitable political and social power with meaningful involvement in healthcare governance, policy development, planning, delivery, and evaluation, people with lived experience, family, caregivers, and peers can provide unique and relevant context upon which to work with and base decisions on. The lived experience of people, families, caregivers, and peer support is shaping the cultural shift from storytelling to evidence. It provides a roadmap to affirmative change. So what makes engagement meaningful? In a book edited by Emily Zimmerman called Researching Health Together, she talks about engagement versus tokenism. So she defines tokenism as organizations or initiatives trying to meet expectations for engagement of the public, patients, and other stakeholders in collaborative endeavors without the opportunity for those participants to have meaningful impact on decision making. So tokenism is doing something for symbolic purposes only. She talks about engagement versus tokenism along 3 domains. So the 3 domains are methods and structures for engagement, which includes things like group composition, how time is allocated for different activities, as well as whether or not communication is open and feedback is provided. The second domain is intent, so the extent to which goals and opportunities are collaboratively determined, whether learning is reciprocal, and whether power is shared. And finally, the third domain is relationship building, which refers to building trust, engaging with each other's perspectives, taking the time to build a relationship before the project, and sustaining it beyond the project. So the extent to which these things are happening will determine whether it's more along the lines of engagement or tokenism. In a paper by Sandra Mull from McMaster University called Are You Really Doing Co-Design? Critical Reflections When Working with Vulnerable Populations, she has a few questions which allow us to think about the readiness of ourselves as well as our context to do co-design and engagement activities. So she said, explore readiness of self and of organization and system by asking yourself, how does my position impact others? How do I make others feel? Am I creating a safe space? Is the organization ready to take on the change that we want to achieve? And these are really important reflective questions that we can do on our own, but also within the communities and organizations that we work in. And this framework, which also gets at core foundational principles to think about when doing engagement and co-design, this framework is the product of a systematic review and synthesis of conceptual foundations and guiding principles of patient engagement in research, but it's also applicable to health system design and quality improvement. And 55 studies met the inclusion criteria set by the co-authors. And the most commonly reported principles were respect and equitable power between all team members. So the most commonly reported best practice for engagement work was education for both patient and caregiver partners and the researchers, so people supporting the engagement work. The goal is not necessarily to turn patients and caregivers into researchers, but to help them understand the research process and for researchers to learn how to engage and pay attention to power and be reflexive. And so along the top of the schematic, you can see some of the foundational principles of engagement. You can see respect and equity, trust and empowerment. Along the bottom, you see the different stages and phases of research. And then the middle part speaks to some of the best practices. So clarifying roles, budgeting and compensation, evaluation, etc. In this paper by Holly Whitteman and colleagues, they drew from their collective years of experience as patients, caregivers, care providers, and other stakeholders and researchers in partnered projects to offer a number of practical lessons they have learned about how to better conduct their work together. So theme 1 was about establishing and maintaining a culture and expectation of mutual respect. So for example, having a full team meeting as early as possible, stating individual and project goals explicitly, and offering an orientation to everyone. Those are just a few examples. Theme 2 was actively involving all team members, offering funding for everyone, checking in on quiet members, inviting people to contribute, and recognizing openly the contributions and efforts of others. Theme 3 was about facilitating good communication, so thinking very carefully about language, being aware of jargon, and occasionally regrouping in smaller homogeneous groups, so having all patient partners together to deliberate, having all providers together, etc. So people had those safe spaces to share, in addition to coming together in multi-stakeholder groups. In this scoping review by Marissa Bird and colleagues, they examined the impact of patient partnership on outcomes, along with barriers and facilitators to realizing effective partnerships. And 14 studies met their inclusion criteria. So in terms of impact, they found that the studies that they looked at, when engaging with patients and care partners, the work or the project was reframed to include things that mattered to patient and caregiver partners. Practical skills were gained by patient partners, their confidence was increased over time, and it increased their peer network. On the other hand, some of the barriers that were articulated by the studies that they looked at was a lack of diversity of participants, time commitments that were hard to meet, power differences between different members of the group, the use of jargon, it was sometimes expensive and time consuming, health challenges sometimes got in the way of people participating, sometimes expectations were misaligned, people didn't always feel heard, and there's lack of thoughtful preparation for both the patient and caregiver partners and researchers. On the other hand, some of the facilitators to doing engagement work was flexibility, openly adopting ideas from patient and caregiver partners, providing skills training, using short digestible summaries, involving patient and caregiver partners in core decisions, briefing and debriefing before and after meetings, and having small groups to create a relaxed atmosphere. So a lot of information was shared. As a quick summary, I'll highlight 4 key things. First, engaging patients, caregivers, and families matters if we want to have collective impact within the healthcare system. Second, patient and caregiver engagement increases the relevance of the work being done. It helps to design meaningful initiatives and can improve patient and caregiver outcomes and experience. Third, in doing this work, we can consider the available frameworks, best practices, and resources to help guide engagement and co-design processes. And that's really the focus of the engagement series that I'll talk about next. And finally, being reflective about our own thoughts and biases and considering how those affect our own readiness as well as that of our communities and organizations that we're part of to engage with patients, caregivers, and families. So a lot of reflection and learning is required in doing this work. That's ongoing. So now I'm going to flip to how the learning series was developed. So how did we get to where we are now? And so back in 2021, myself, along with other community partners, patient and caregiver partners, trainees, other researchers, and faculty members, developed a course on patient and caregiver engagement in research at the University of Toronto. We've offered it for 2 years, and it continues to get better and better and attract more students. After the launching of that course, we realized that we might be able to repurpose some of this content for a healthcare audience and realized that from what we were hearing that Ontario health teams had expressed learning needs related to engagement and co-design. So from there, we created a steering group and started to co-create and design curriculum, and our team continues to grow as we develop this. So in order to create our common vision, we created a terms of reference. And our mission was really to fill a learning need among the Ontario health teams and the broader health system. We determined the scope. So we wanted to focus on organizational level engagement. We set our objectives, which was to co-design a multi-part virtual curriculum about patient and caregiver engagement. We collaborated with Ministry of Health, Ontario health teams, the RISE network, and others to ensure alignment in engagement activities and initiatives. And then finally, we're in the stages of implementing, and we will evaluate and modify the curriculum as we go along. Who have we engaged with? So we have our core sponsor of the Ontario Strategy for Patient-Oriented Research, who provided us with some funding support, mostly to compensate the people who have been co-designing the curriculum as well as those delivering the curriculum. So patient, family, and caregiver partners, student learners, researchers and research staff, healthcare leaders and OHT staff, and external content experts. What have we accomplished to date? So as I mentioned, we identified our mission and our terms of reference. We brainstormed the structure of the curriculum, areas of focus and competencies. We considered, and in line with competencies, we considered the skills, knowledge, and attitudes that participants should obtain from taking this course, and then use that as the basis to design the different sessions. We worked closely with the ministry and others to map out our areas of focus onto some of the building blocks of the ministry, and then we co-created the sessions. Before developing each of the sessions in the engagement series, we co-designed a number of competencies that we wanted people who took the series to walk away with. And these different competencies listed here have been embedded into different sessions in the learning series. So I've categorized each of the competencies into participatory approaches, engagement values, roles, responsibilities, and boundaries, open communication, impact, equity, diversity, and inclusion, and collaborative teamwork. And so if interested in obtaining the fuller document, which outlines how we develop the competencies and some of the details of each of these categories, you can email me to access that, and I provide my email at the end of the presentation. When we worked with our steering group, we got key pieces of feedback. We got feedback on the scope and the flow of curriculum. We developed competencies that would reflect both patients, caregivers, and staff. We ensured that our work aligned with other initiatives happening in the system. We leveraged the expertise of colleagues for each topic area. We were asked to introduce EDI and person-centered philosophy at the beginning, but also through the curriculum. And we created a space, and we were asked to create a space for peer learning and reflective practice. So each of the sessions, again, there's 90-minute sessions offered every month, starting in December. We'll be doing a theory burst, so sharing core information, and also doing interactive work so we can practice the skills and concepts that we're learning. And also there will be take-home handouts, so you can go back to your communities and OHTs to work on some of the things that you've learned together as a group. So now let's provide an overview of the sessions. Session 1 is focused on communication, compassion, and empathy, being delivered on Zoom on December 5th from 11:30 to 1. And this particular session was developed in partnership with Support House's Center for Innovation and Peer Support, where the director is Betty Lou Christie. And the team working on this module is Richard Adair, Alyssa Gremin, Ethan Hopkins, and Irene Wright. And the focus of the session is to learn about key practices in relationship building, including active listening, demonstrating compassion and empathy, and building rapport. Session 2, offered in January, is about bearing witness to lived experience, where you'll learn about the risks and benefits of sharing lived experiences with healthcare decision-making councils, education events, and co-design teams. We'll discuss facilitating, receiving, and responding to lived experience and emotions in meetings with patient and caregiver partners, including creating safer spaces and using trauma-informed engagement practices. Equity, diversity, and inclusion will be the topic in February, where we're going to learn about the impact that privilege and power dynamics have on communication and relationship building, the value of anti-oppressive approaches, and ways to mitigate bias. Session 4 in March is about leaning into the challenges. So we'll talk about miscommunication and conflict, how to address that, how to co-develop resolutions, and how to move forward. Session 5 in April is about preparing for engagement activities, where we're going to explore strategies and learn how to get ready for engagement and co-design activities, including recruitment, onboarding and preparation of staff, community, patient, and caregiver partners. Session 6 is about engagement methods, where we'll experience live simulation and practice various co-design strategies and the use of different virtual platforms. We'll learn how to co-design in a way that avoids tokenism, eliminates barriers to engagement, and tailor engagement methods to different individuals and groups. Session 7, last but not least, is on evaluation. In June, we'll learn how to design and implement a strategy to evaluate engagement activities. So we'll learn how to participate in the process of continuous learning and improvement of engagement practices. So why is it important to do the full series? So the sessions are curated as a linked series. So as I mentioned, one session per month, 90-minute sessions. And as a whole, the learning series provides a comprehensive introduction to core foundational principles and practices of engagement and co-design. The sessions are free. The intended audience is we're targeting multiple stakeholders from each OHT who are encouraged to attend and apply learnings in practice. And you don't have to be a member of an Ontario Health team. I think anyone working in health and social care or have experience as being patients and family members will gain some important foundational knowledge from this. But the way we design the sessions is they're particularly geared to patient and caregiver partners and stakeholders, so system leaders, providers, engagement leads, et cetera, who work in partnership with patients and care partners. And I will finish off with a quote by the late Brenda Zimmerman, a well-respected professor of policy strategic management at the Schulich School of Business at York University. And she said, the most important unit of analysis in a system is not the part, so not the individual, organization, or institution. It's the relationship between the parts. And really the essence of this whole engagement series is to learn how we can build better relationships together, work across our individual and organizational boundaries in partnership to achieve improvements in our health and social care systems. So that concludes the presentation. For more information and to receive the flyer overviewing the sessions and registration links, you can email me at the email provided here, which is carrie.koleski@thp.ca. We will be recording the sessions and posting them afterwards, so I'll provide some updated information as we launch the series on how to access those recordings. Thank you so much for your time today. I do hope that you're able to participate in the learning series, and I look forward to seeing you on Zoom.